Hello, good morning all. Welcome to the grand finale, day 7 of the CAMS Medmeet International UG Conference, an initiative by College Union 2020, Government College Kolkata. This will be the first session of the final round of the medicine case presentation. We have an eminent panel of judges with us today. Dr. Jayesh Kumar, Professor, Department of General Medicine, Government Medical College, Kolkata. We also have Dr. Danish, Assistant Professor, Department of General Medicine, Government Medical College, Kolkata. Dr. Danish will be joining us in the next half of the session. I humbly welcome Dr. Jayesh to this event. Here are the general rules for the event. This session will be conducted in two halves, with different judges for each session. On both the halves, the participants will be given one short case each. The first case will be discussed with Dr. Jayesh in the first half of the session. In the second half, Dr. Danish will take the position of Dr. Jayesh, and then the second case will be discussed. All the participants will be given 30 minutes time prior for preparation. Each participant will then be given 15 minutes time for discussion of the case. A reminder will be given at 10 minutes. The participants are required to keep the camera and mic on while speaking. Please note that these rules will be strictly followed. We shall now start with the session. Sir, may I call in the first participant?
Yes.
Please note, this is test number 1.
Hello.
Hello, sir. Test number 1 will be joining shortly.
Okay. വാട്ടർ വേണമായിരുന്നല്ലേ വെള്ളം ഇവിടെ ഉണ്ടാവും.
Test number 1. Test number 1. Can you hear me? Hello? Can you please on your audio?
Hello? Am I audible?
Yes, you are audible. I hope you're ready with your presentation.
Yes.
You'll be given a total of 15 minutes for your discussion. You'll be given a time reminder at 10 minutes. Say this
Okay.
all the best, test number 1.
Thank you.
Sir, you may start.
Uh, I can't see actually anyone.
Is the presentation visible?
No, I can't see it. Should I rejoin the chat?
Can you please try?
Uh, should I rejoin the chat?
Can you please try clicking on the name Femina?
Okay. I can see individual people.
Can you please present once again?
Okay. Yes.
Can you see now?
Yes.
Okay. Sir, you can start the session now.
Good morning, sir. Sir, I can't hear you.
Hello, Jay, sir. Can you hear me?
Hello, sir.
Hello, sir. Test number one, I'm really sorry for the delay. Can you please wait for a
No
minute?
problem. Yeah, no problem.
Hello, sir. Jay, sir. Can you hear me now? Sir, can you please unmute? Hello? I can't hear you, sir. Hello? Test number one, I'm really sorry. He'll be joining in a moment.
No problem. No problem.
സ്ട്രീം ഓഫ് ആക്കിയിട്ട് ഒരിക്കൽ കൂടെ ചെയ്യാം. സാറിന് ജോയിൻ ചെയ്യാം.
എന്താ?
സ്ട്രീം ഇപ്പോൾ ഓഫ് ആക്കിയിട്ട് സാറ് ഇനി ജോയിൻ ചെയ്യും. അപ്പോഴ് പിന്നെയും തുടങ്ങാം.
അപ്പോ എന്താ പറയണ്ടേ?
ഇപ്പൊ പ്രത്യേകിച്ചൊന്നും പറയണ്ട. വെയിറ്റ് ചെയ്യാൻ പറഞ്ഞാൽ മതി.
അല്ല, ഇപ്പൊ യൂസ് ചെയ്ത് തുടങ്ങാം. പിന്നെ നമുക്ക് കട്ട് ചെയ്ത് ഒഴിവാക്കിയാൽ മതിയല്ലേ ഈ പാർട്ട്?
ഓക്കെ.
Yes, number 1, the judge will be joining soon.
Yes, no problem.
Hello, sir.
Size of the column. Sir? Okay.
ഇതിപ്പോ ഇനി എത്രമാത്രം റെഡിയാവുന്ന എനിക്ക് അറിഞ്ഞൂടാ.
Hello?
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 Hello? I can hear you, sir.
എനിക്ക് കേൾക്കുന്നില്ലേ?
The volume file window.
രണ്ടു വോളിയം പോയി.
Hello?
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 Hello? Can you hear me?
Volume.
വൈഫൈ കിട്ടിയിട്ടില്ല. സ്മോളല്ലേ?
ഇതിപ്പോ കണക്റ്റാ അല്ലല്ലോ?
ഇത്
വീണ്ടും വോളിയം പോയോ?
ഇല്ല, സാറിന്റെ മൈക്ക് വർക്ക് ചെയ്തില്ല, അതാണ് പ്രശ്നം.
അല്ല, ഏതാണത്?
ഏതാ
ഇത് സോഫ്റ്റ്വെയർ.
ഹലോ?
അത് ഗൂഗിൾ മീറ്റ്.
കേൾക്കുന്നുണ്ട് സർ.
നിങ്ങളുള്ള വോളിയം ഇല്ല.
അടുത്തൊരു പ്രശ്നം ഉണ്ടാകും.
ഇതില്
ഓഡിയോന്റെ ഒരു പ്രശ്നം ഉണ്ടാകും.
ഈ റൂമില്ല.
ഈ റൂമല്ല, ഗൂഗിൾ മീറ്റിന് അങ്ങനെ ഒരു പ്രശ്നമുണ്ട്.
ആ,
കേൾക്കാം. ഇവർക്ക് നമുക്ക്
നെറ്റ് ചെയ്ത് കൊടുത്തു സാറ്.
സാറിന്റെ
ഉം.
വരുന്നില്ലല്ലോ. ക്ലോസ് തന്നെ. കാൺ കണക്ട് ദിസ് നെറ്റ്വർക്ക്.
സ്മോൾ അല്ല.
വീണ്ടും 1 2 3 ഇല്ല അല്ലേ?
ഒരു മിനിറ്റ്.
എനിക്ക് വെള്ളം മുഴുവൻ കൊടുത്തുവല്ലോ.
Sir, can you try putting on a headset?
ഓക്കെ, ഇതിലൊന്ന് എടുത്തേക്ക്.
വാട്സാപ്പ് ഉൾപ്പെടെ
റെഡിയാ?
ഒരു ഫാൻ വേണമെങ്കിൽ അതിലിട്ടാ മതി. സ്വിച്ച് അധികം
റെഡി. ഓക്കെ, എന്റെ ലാപ്ടോപ്പ് ചെയ്താൽ മതി. ഒരു പ്രശ്നമില്ല. ഇതൊന്ന് സാർ താഴ്ത്തി വെച്ച്
ബാറ്ററി ഓഫ് ആക്കട്ടെ.
ഓഫ് ചെയ്തു.
Test number 1, I think it would be better you can come join in after the judge comes.
Okay, no problem.
Thank you.
Thank you.
സാറ് നമ്മൾ പറയുന്ന അവിടെ കേൾക്കുന്നില്ല എന്ന് തോന്നുന്നു. സോറി.
അതാവും നല്ലത്. Hello, sir.
ഓക്കെ.
Can you hear me now?
ഇപ്പൊ കേൾക്കുന്നില്ലേ?
കേൾക്കാം. നേരത്തെ കേൾക്കുന്നുണ്ടായിരുന്നു, sir. ഞാൻ പറയുന്നത് അങ്ങോട്ട്.
നമുക്കൊന്നും കേൾക്കണ്ടായിട്ടില്ല. അത്രേ ഉള്ളൂ. ഒരു മിനിറ്റ്, ഞാനൊന്ന് ഇതൊന്ന്. ഓക്കെ, ഇത് എൻ്റെ ലാപ്ടോപ്പിലേക്ക് മാറ്റിയതാണ് ഞാൻ. ഒരു മിനിറ്റ്. കാൺ ഷോ ഇൻ എ ടൈൽ ഇൻ ദിസ് ലേഔട്ട്. ഓക്കെ, ശരി. ഇപ്പൊ വോയിസ് ക്ലിയർ അല്ലേ?
Yes, sir.
ഇപ്പൊ എല്ലാം
ക്ലിയർ ആണോ?
ഇപ്പൊ എല്ലാം റെഡി ആണല്ലോ? എന്നാല് സ്ക്രീനിങ് സ്റ്റാർട്ട് ചെയ്യാം. ഞാൻ എന്റെ വാട്സാപ്പ് ഇതിൽ ഓഫ് ചെയ്യട്ടെ. എന്തെങ്കിലും ഒച്ച വന്നോണ്ട്. ഇപ്പൊ റെഡി ആണല്ലോ? സാറിനെ കാണാലോ? പ്രസന്റ് ചെയ്തോ?
Okay,
Okay,
sir.
sir.
Can I call you?
Yeah, call.
Will be joining.
ഫാൻ ഒന്ന് വേണോ?
Hello, test number 1.
Hello.
Can
Hello.
You may start. Can you see the presentation?
Yes, currently I can't see presentation.
We wait for a minute.
Okay.
Please let me know when you can.
Yes.
Test number 1. Can you see?
Yes, I can see the presentation.
Okay, you can start. Sir, you may start.
Good morning, sir.
Good morning, good morning.
So should I present the case?
But I can't see you. Huh? You present. Okay, present.
Okay, sir.
Hmm.
Sir, a 38-year-old female came with chief complaints of exertional palpitation since 3 years and progressive dyspnea on exertion since 1 year duration. Next slide, please.
Okay. Okay. Right. Proceed, go ahead.
Next slide, please.
Can the slides be switched to?
So the next slide has a question.
Yes.
Your symptom analysis and approach.
Okay. So you have two symptoms, no? So
Yes, sir.
you have to analyze the symptom and fix what is the problem of this patient.
Yes, sir.
Okay.
So as she is having palpitation and dyspnea, we'll first
Yes.
like to rule out cardiovascular causes and respiratory causes.
Very good. Yes.
Sir, we can do that by the history. Like palpitation points more towards the cardiovascular cause.
Okay.
Dyspnea, which is related to exertion points towards cardiovascular cause more than
Okay.
respiratory cause.
Right. So if it is a cardiac, now is it a left side or right side problem?
So
Dyspnea.
left heart
Left
problems.
heart. Okay. Suppose if it is right heart, what do you expect?
So we expect there will be hepatomegaly, there can be ascites, there can be
Yeah.
generalized edema, raised
Yes.
GVP.
Yeah. Okay. Very good. Yes. Go ahead. Yes. So palpitation, your approach.
So palpitation, we'd like to find out what is the cause of palpitation here.
Hmm.
Like, is it due to arrhythmia or due to
Yes.
any cardiomegaly?
Cardiomegaly. Can you get more specific?
Sir,
So
left
one
ventricular
is
hypertrophy.
arrhythmia you told, what correct? Arrhythmia related palpitation and mechanical causes for palpitation.
Yes, sir.
Hmm. Like,
So there
is
can
there
be other.
oh,
So there can be other causes like
yeah.
hyperthyroidism.
That is yeah, thyrotoxicose you can have, yeah.
Yes,
Then
sir.
hmm.
So
Cardiac, yeah. Hmm. Yes,
left
come.
atrial enlargement, which can lead to
Left
atrial
ear.
fibrillation.
Okay, that is again arrhythmia related.
Yes, sir.
Suppose the patient is not having arrhythmia like atrial fibrillation or flutter or ectopic,
Yes, sir.
but they are complaining of palpitation. In sinus rhythm, when the patient is having sinus rhythm or tachycardia, still, I
Yes,
mean,
sir.
rhythm, not tachycardia, then what are the causes where you can
So,
get exceptional palpitation? Can you say a few other?
sir, in thin chest wall patients, in thin patients, they can feel palpitation.
Hmm. No, when how will you approach? No, if a person is coming to the cardiac problem, you have
Yes, sir.
cardiac, then you have vascular. Then
Yes, sir.
suppose a cardiac problem, left side, then how will you approach? Your approach should be valve. Okay, then it can be myocardial disease. This can be a pericardial disease. This can be a coronary disease. This can be a shunt, or then it is vascular cause like systemic hypertension,
Yes, sir.
peripheral vascular disease, coarctation of aorta,
Yes, sir.
tachyarthritis, atherosclerotic involvement of aorta, radiation arthritis. They are all vascular part. Okay.
Yes, sir.
Vascular part you will diagnose by palpation, auscultation for Brody, everything. And cardiac portion you have inspection, palpation, percussion, auscultation. This
Auscultation.
is how you approach cardiac.
Yes, sir.
Vascular, palpation, and Doppler, and your auscultation technique. Isn't it? So these are the two set of approach, vascular side and cardiac. My question is, when you have cardiac, no, you have to think already valve, shunt,
Valvular effusions.
cardium, pericardium, coronaries.
Yes, sir.
These are the acquired heart disease, isn't it? Okay. So now my question is, which are the heart disease where you can get exertional palpitation as a presentation? That's why it's valve and shunt and myocardial disease, coronary. Same.
Sir, we can get in valvular heart diseases like
Like,
mitral stenosis, causing left atrial enlargement, or regurgitation lesions like mitral
yes,
regurgitation
very good.
or aortic regurgitation.
Aortic regurgitation, very good. Any shunt lesion?
Sir, sir, in VSDs there can be palpitations.
Okay, any much more common, any other shunt lesion that you know palpitation will be present if you are at the age of 40?
Sir, ASDs, atrial septal defects.
Defect, that's it. Okay, right. Right, correct.
Yes, sir.
Okay, go ahead. Hmm.
Sir, in cardiomyopathies, there can be palpitations. Like dilated cardiomyopathy can present as
Yeah.
palpitations.
Yeah. Why do they get palpitation? What is the mechanism?
So there is a left ventricular systolic dysfunction. So to compensate, the heart beats more powerfully, and there is palpitation.
You mean the cardiac output declines, stroke volume increases, isn't it? Heart
Yes,
rate?
sir.
Okay.
So Frank
then,
Starling's law also.
Yeah. Okay,
Yes.
right. Hmm. Okay, right. Can you say some endocrine cause for dilated cardiomyopathy?
Sir, there can be thyroid related like hypothyroidism.
Hyper. You mean
Hyperthyroid.
that? Yeah.
Yes, sir.
Hmm.
Uh,
Then,
Sir, sometimes there can be postpartum cardiomyopathy, which can be
Okay.
dilated cardiomyopathy, endocrine cause.
That's the situation now. My question is endocrine causes for palpitation.
Yes, sir.
Pyrotoxic is correct.
Uh,
Acromegaly.
acromegaly, yes, sir.
Syndrome.
Yes, sir.
Okay, right. Pheochromocytoma.
Yes, sir. Episodic palpitations can be seen.
Okay, DCM. Dilated. Okay, right. So now coming back to your case, now you link exertional dyspnea and exertional palpitation and say possibilities.
Sir, the here exertional dyspnea and palpitation points towards cardiovascular causes. There can be valvular heart diseases, which can lead to left atrial enlargement and left-sided heart failure, causing pulmonary
Okay.
edema, and these features. So mitral stenosis can be one.
Okay,
Mitral
then
regurgitation can be another. Mitral
yes.
valve prolapse.
Okay, then
So,
mm.
so
And
there can
aortic valve disease.
so aortic regurgitation can be the reason, but
Okay, any congenital heart disease?
sir, in tetralogy of Fallot,
No, that is a different presentation, no? But here,
yes, sir.
congenital heart disease, atrial septal defect, you already answered.
Yes,
Okay.
yes, sir.
Yeah. Then you go ahead.
Sir,
Go
other
ahead.
causes.
Okay. All right. Now you again presentation. You continue. Next slide. Hello.
Yes, sir. So on an examination, the pulse rate is 102 beats per minute, which is
Yeah.
irregularly irregular, and the
Yeah.
blood pressure is 130 by 80 millimeters of mercury.
Okay.
So the JVP is not elevated.
Hmm.
On inspection, we can see precordial bulge is present. The apex beat is on the fifth left intercostal space, 1 centimeter medial to the mid-clavicular line, and it is diffuse. There is presence of left parasternal heave. Prominent pulsation can be felt.
Pulsation. Pulsation.
Yes, sir.
Because you are now presenting inspection findings.
Yes, sir.
Okay. That's a left parasternal pulsation. Okay. Then?
Sir, on palpation, left parasternal heave is present.
No, inspection wise, what do you think? Inspection. After general examination, what information you got?
So that the JVP is not elevated, precordial bulge is seen.
General examination, what is a striking finding?
So the pulse rate is tachycardia and irregular rhythm.
That means what do you think now?
Sir, atrial fibrillation.
Atrial fibrillation. Okay. What are the cause for other totally irregular pulse? It's a very simple question.
Sir, regularly irregular and irregularly irregular pulse. So
Yes,
one can be atrial fibrillation. There can be ventricular premature contractions or ectopic beats.
You mean true frequent ectopics? Okay.
Yes,
what
sir.
about atrial flutter with varying block?
Sir, in atrial flutter, sir, it will be variable.
Yeah. So these are the three important causes for totally irregular or irregularly irregular pulse. So here, what do you think? Most common is atrial fibrillation. Okay.
Yes.
Right. So can you say a few causes for atrial fibrillation?
Sir, there can be
Cardiac cause.
so stenotic lesions like mitral stenosis.
Now, whenever a question is asked in the cardiac system,
Yes,
you
sir.
have to think valve, shunt, myocardium, pericardium, coronary, and blood affecting blood vascular. That is aorta and its branches. Right?
Yes,
now you answer.
Sir, in valves, you can have mitral stenosis, mitral regurgitation,
Right.
aortic regurgitation.
Valves, then shunt.
Sir, in shunts, we can have ASDs.
Myocardial disease.
So atrial fibrillation can be present in dilated cardiomyopathy and restricted cardiomyopathy.
Then any other cardiomyopathy, will you within hypertrophic obstructive cardiomyopathy, atrial fibrillation? When they develop atrial fibrillation, they deteriorate fast.
Yes, sir.
Yeah, hypertrophic cardiomyopathy, isn't it?
Yes,
Then
sir.
congestive pericarditis, will you get atrial fibrillation?
Sir, if there is
Sorry,
a
12 minutes are over.
Okay. Okay, right. Go ahead with your presentation. So palpation. Hello, hello.
Hello, chest number 1, are you there? Hello, chest number 1. Sir, I guess there is a network issue in the participant side. We'll wait for a minute.
Okay, some problem with that. Hello,
Hello,
what happened?
there is some network issue in the participant side. We'll check.
Okay.
We'll let you know. Hello, chest number 1.
yes, there was some technical issue.
Okay. Now I can hear you. Okay, come. What is the incidence of? Hello.
Hello, sir.
What is the incidence of atrial fibrillation in congestive pericarditis?
Sir, sir, it can happen when there is not enough room for the ventricles to dilate.
No. Around 30% of the patients can have atrial fibrillation, isn't it? Right.
Okay, sir.
So again, coronary artery disease, will you get atrial fibrillation?
Sir, we can get if
Yeah.
the branches supplying the atria are affected.
Yeah. Hello?
Yes, sir.
Okay. Go ahead. Palpation.
So in palpation, there is
Hmm.
left parasternal heave is present. There is
Hmm.
prominent pulsation felt in the left second intercostal space close to the
Hmm.
sternum,
Hmm.
and second heart sound S2 P2 component
Hmm.
is palpable.
Hmm. Okay, that's it. Okay. So
Yes, sir.
what is your diagnosis now?
Sir,
Possibility. Hmm.
sir on pal-
Inspection and
sir on inspection, the apex beat is
okay. No. Okay. In the apex beat is.
sir, it is almost on the normal range,
Hmm.
like fifth intercostal space, and just medial to the midclavicular line.
Okay. So what is the striking finding you got?
Sir, left parasternal pulsations and left parasternal heave.
Okay. That indicates what?
Sir, right ventricular hypertrophy or left atrial
Right
enlargement.
ventricular hypertrophy. What is the common cause of right ventricular hypertrophy characterized by pulmonary P2 and RVH?
Sir, pulmonary hypertension.
Okay. When a person is having pulmonary hypertension, how will you approach? How will you think?
So we have to first rule out it is due to cardiac cause or it is due to primary pulmonary hypertension.
Okay. So you will think, is there any cause on left side,
Yes,
right
sir.
side,
Right side.
or is there any shunt in between? Isn't it?
Yes, sir. Yes, sir.
Okay. Is there anything on the left side like MS, MR, AS, AR?
Sir, MS and MR can present with pulmonary.
No, any evidence in this patient? Are you getting any chance for AR or MR?
Sir, for MS, I can think because there is presence of atrial fibrillation because of the pulse,
Yeah.
irregular.
Well, what palpatory finding you will get in the apex in MS? What is the nature of apex?
Sir, there will be tapping apex in MS.
So is there present here? Is it present?
Sir, there is no mention of
Not mentioned.
palpation. No,
In
sir.
MR, what apex you will get?
Sir, in MR we'll give uh,
Forceful.
thrusting effects, sir.
You mean forceful apex.
Yes,
Okay.
sir.
In AR, what finding you get?
Sir, in
What will happen to pulse?
sir,
Here
pulse
also
is
there
what?
is an atrial fibrillation. Yeah, you get now blood pressure change and peripheral signs of aortic regurgitation, cardiomegaly, anything present here?
So there are no signs of narrow pulse pressure as seen in aortic regurgitation. There is no
Yeah.
water hammer pulse
Is
mentioned.
there anything suspect BCM or hypertrophic cardiomyopathy here?
No, sir, because it is chronic history. So,
Yeah.
and dyspnea is also present. So, hypertrophic obstructive
So,
cardiomyopathy is less likely.
okay. So you think the pulmonary hypertension is not due to a valve or a myocardium or a pericardium or coronary or hypertensive heart disease on the left side, isn't it? Huh?
Sir, I think it is due to valvular heart disease, like mitral stenosis.
Mitral stenosis, okay,
Yes, sir.
possible. Any other possibility?
Sir, uh,
Any shunt?
sir, ASDs can present with.
ASD is 10%, very good. Atrial septal defect, isn't it? Whereas in
Yes, sir.
VSD, you'll get biventricular enlargement.
Yes, sir.
And
Biventricular hypertrophy.
again, if it is PD, again, you can get a left-sided enlargement, a continuous thrill, nothing is described. Isn't
Yes,
it?
sir.
Thrill is
Yes,
not
sir.
described. Okay, VSD also you get left upper sternum thrill, that's
Yes,
also
sir.
not described. So the
Sir,
atrial septal
most
defect,
likely.
mitral stenosis versus
Yes,
atrial septal defect. Suppose there is no ASD, no
yes, sir.
EMR, what other possibility you will think?
Sir,
Anything on the right side?
sir, pulmonary regurgitation.
No, that is secondary to pulmonary hypertension now, isn't it?
Yes, sir.
Have you heard entity called primary pulmonary hypertension? Have you heard?
Yes, sir.
Huh?
Yes, sir.
Very good. What is that?
So there is a propensity of the pulmonary vasculature to be more concentric and more thick, uh,
Hmm.
leading to pulmonary vascular constriction, and
Yeah,
that is causing pulmonary hypertension.
that is primary pulmonary hypertension. A condition that can closely mimic primary pulmonary hypertension is what?
So,
Have you heard pulmonary embolism? Two types, acute and chronic.
yes, sir. Yes, sir. The
Which
chronic one
condition?
can present.
Chronic?
Chronic pulmonary embolism can
Chronic
present.
thromboembolic pulmonary hypertension. Isn't
Yes,
it?
sir. Yes,
Okay,
sir.
that can. Okay, right. So in atrial septal defect, what for? So what is your question? ASD findings, auscultatory findings of atrial septal defect term.
Sir, there will be wide and fixed second heart sound.
Very good. Yes.
Uh, Sir, first heart sound will be normal,
Mm.
and so there will be presence of a murmur.
What murmur you will get in atrial septal defect?
Um,
Which what all murmur you will get?
so we can get a
Hmm.
systolic murmur.
In the pulmonary area due to
So due to the flow of due to left to right shunt.
left to right shunt. Okay, high volume
Yes,
passing
sir.
by normal. Okay, right. Then
Sir,
other murmur you will get in ASD. Will you get any shunt murmur? Yes or no? Due to that,
sir, I can't hear you.
because in ASD there is a left to right shunt in atrium. No,
Yes, sir.
whether that shunt will
Yes, sir.
produce any murmur? Yes or no?
Sir, it depends on the size of the defect in the atrial wall.
No, that shunting across the atrium will it produce any murmur? That's my question.
No, sir, because the pressure gradient is not that much.
Yeah, that's it. Okay, correct, good. Then what is the first murmur you get? Will you get any murmur in the tricuspid valve?
Sir, we can get tricuspid regurgitation.
Tricuspid regurgitation or mid-diastolic murmur in the across the tricuspid valve. What will you get?
Sir, mid-diastolic murmur will get.
What is the reason?
Sir, because of the increased blood flow from the right atrium to the right ventricle
Very good. That's
during
it.
filling of the filling
Okay, when
phase.
will you get tricuspid regurgitation related murmur in ASD?
Sir, when when there will be shunt reversal,
Yeah, when the person develops severe pulmonary
heights and
arterial
fingers.
hypertension, functional TR. What is
Yes, sir.
ostium primum ASD?
Sir, it is the first defect present in the atrial wall due to the failure of closure of septum primum.
Yeah, what is the finding you'll get? How will you clinically diagnose?
Sir,
What are the other association of ostium primum ASD? Endocardial cushion defect. What will happen to mitral valve? What will happen to interventricular septum? What will happen to tricuspid valve?
so the mitral valve and tricuspid valves, due to endocardial cushion defect, they will show regurgitation lesions.
Yeah, that's it. So associated MR or
MR and
TR
TR.
or associated VST will tell you that is ostium
Yes,
primum,
sir.
isn't it? Right,
Yes, sir.
very good. Yeah, right. In which college you are studying?
Sir, my undergraduation is from Srimati Kashibai Navle Medical College, Pune.
Very good, very good. Good, right. Then, hello?
Yes, sir.
Okay. That is ASD related finding, okay? In
Yes, sir.
chronic pulmonary thromboembolic pulmonary hypertension, what finding?
Sir, sir, palpable P2 can be present due to
Yes,
pulmonary
then,
hypertension.
yeah.
So there can be left parasternal heave, epigastric pulsations, visible
Right.
pulsations in
Okay.
pulmonary.
How will you manage atrial fibrillation?
So we have to control the rate and the rhythm.
Yeah.
So, and also we have to give anticoagulants to decrease the
Right.
chances of thromboembolism.
Okay.
Sir, so for rate and rhythm, we like to give calcium channel blockers, beta blockers,
Yeah, right and
digoxin.
rhythm.
Yes, sir.
Right control is the rhythm control. How will you control rhythm? That is,
So,
you are converting atrial fibrillation back to sinus
sinus
rhythm.
rhythm. Yes, sir.
Chemically or electrically? Chemically, which are the drugs?
Sir, amiodarone can be given, digoxin can be
Yes.
given.
Digoxin.
Uh, yes, sir. So for rate control.
My question is rhythm. Atrial fibrillation back to sinus. Which are the drugs? Amiodarone you said.
Sir,
Yeah.
amiodarone, sir, adenosine
Yeah,
can be
then
used.
adenosine. Any other
Yes.
drugs? There are more drugs
Sir,
now.
ebutilide can be used.
Then,
So we can use
okay, no problem. Rate control.
so beta blockers or calcium channel blockers can be used.
Which calcium channel blocker? Will you give nifedipine like?
So we'd like to give verapamil like more acting on the heart.
Sorry for interrupting. 20 minutes are
Oh,
past.
I think we have as one candidate already left. No, I mean he's not participating, so I thought we'll get enough time. Is it like that? We have
Sorry,
only three candidates now.
sorry, sir.
Actually, we had four candidates. One
Yes, sir.
is not one candidate backed off, isn't it?
Yes, sir.
So I think three.
Okay,
So
sir.
he's
We can take 5 more minutes.
five. Okay, right. Okay, right. Hmm. Hello.
Yes, sir.
Okay, right. Come. That's about okay. Right. Atrial fibrillation, rate control, rhythm control. All you told. Okay, right. And discussion is good. All right. Okay.
Yes, sir.
Good. Okay. Hello.
Yes, sir.
Right. So any questions left in that? All answered now.
So auscultatory findings were asked
Yeah.
and
And what is the
symptom.
final question? Okay.
So, yes, sir.
So finally, what do you think? This person, because you are not auscultation part, you are not. We have not given you the data.
Yes, sir.
Okay, but you answered it almost good. Okay, no problem. All right.
Okay, sir.
Next case. Next case. Hello.
Yes, sir.
Your next case. One case. Okay. Okay. Right. Right.
So, sir, have you finished with this session?
Finished.
Okay, thank you, test number 1.
Thank you. Thank you, sir.
Welcome.
Yes, thank you.
So please note that was test number 1. Sir,
Yeah.
shall I call it test number 2?
Oh, call.
സാർ ഡാനിഷ് സാർ
Danish.
Yes.
ഇതിന് ശേഷമുള്ള സെഷന് സാർ റെഡി അല്ലേ?
ready.
12:30 12:15 ആ സമയത്ത്.
Ready.
ഓക്കെ.
One minute.
Test number 2. Test number 2. So, test
Hello.
number 2.
Yes.
Can you please on your audio?
Mia.
Test number 2.
Hello.
Can you please on your audio?
Hello. Am I audible? Hello.
You're
Yes, you are
audible.
audible. I hope you're ready with your presentation.
Hello.
Hello.
Hello. Am I audible?
Yeah, audible.
Yeah, good.
I hope you're ready with your presentation.
Yes.
You will be given a total of 25 minutes for your discussion. I'll be giving time notification every 10 minutes. The stage is all yours.
How much time?
25 minutes.
Okay, fine. So, we won't be having the second session
You will be having the second session soon.
as well, right?
Sorry?
We will be having the second session, 1B as well, right?
Yes, you will be having the second session.
Okay, fine.
Are you ready?
Yeah.
All the best.
Yeah,
Sir,
thank
may
you.
take over.
Good morning, judges.
Yeah, good morning. Present.
Yes. I have been given a history of a smoker who is a 70 years old male who has presented with chief complaints of progressive dyspnea on exertion since 6 months, loss of weight since 3 months, dry cough, and recurrent episodes of hemoptysis since 1 month duration. And currently, he presents with chest pain and increase in dyspnea. Examination findings which have been given to me are there is there is a
No,
palpable
again,
right. Yes, sir.
one second. Hello.
Hello. Yes, sir.
Let me. So after hearing that history, so we'll go
Yes, sir.
analysis of history, then
Yes, sir.
analysis of general examination finding and its correlation with the history, and
Yes, sir.
then we will go to the system proper and investigations. Okay.
Okay.
Am I audible? Okay, right. So now your
Sir, there
duty
is
is to
some
analyze
echo.
the history.
There is some voice echo. Can the organizers please sort this audio problem?
Now, okay, now can you hear?
Yes, sir. Now it is better
Okay, now
audible.
you analyze the history, available symptom analysis and
Okay, sir.
system localization with possible, I mean, anatomical plus pathological approach. And you, isn't it? So what are the symptoms?
He has been having progressive dyspnea on exertion since past 6 months.
6 months
That,
history of dyspnea. How will you approach?
Yes.
System?
It can be a respiratory system cause, or it can be a cardiovascular system cause, or based on the first
Cardiac
point.
cause. Okay, right.
Yes.
Or any other condition where you can get dyspnea?
It can be because of hematological, maybe because of chronic
Okay,
anemia.
anemia-related symptom, right. Okay, right.
Yes.
Then, any other? Any other cause? Suppose there is no left heart, no respiratory, no hematological anemia. Yeah?
Endocrine involvement.
Yes. Then?
There can be some trauma.
Trauma, produce pneumothorax, contusion lung, etc., etc. Then? Yes? Okay, right. So dyspnea, second symptom. So here, what is the difference between cardiac dyspnea and respiratory dyspnea?
Generally, in case of a cardiac dyspnea, we generally get dyspnea which is followed by cough, whereas in respiratory dyspnea we generally get cough which is followed by dyspnea. Other than that, the dyspnea in case of cardiac case worsens as the day progresses. And along with that,
now in the mechanism of production of dyspnea, what is the difference between heart and lung?
Because
Respiratory.
in case of heart, it will be because of the back pressure mechanism which will occur.
That means in cardiac dyspnea, it is always due to fluid, either in the interstitium or in the alveoli. That is pulmonary edema related, isn't it? Main mechanism. Whereas in respiratory dyspnea,
it can be also because of ventilation pathology.
It depends. Now, each condition that is producing dyspnea, the predominant mechanism varies, like asthma, airway, COPD, airway plus parenchyma.
It can be airway,
Fibrosis, replacement. Okay. Yeah. So each condition varies.
Hello, there
in
is
the
a
mechanism of
audio
genesis.
problem. Hello.
Audio problem? Some problem?
Test number 1. Can you please?
The voice is cutting.
Sir is asking. Maybe that.
This is test number 2. No, your number is 2.
Test number 2. I'm really sorry. Test number 2.
Oh, yeah.
Can you please mute yourself when sir is asking questions? Maybe that would be the cause of echo. Sir, can you please ask now?
Okay, right. Go ahead with the presentation. So that is the first symptom is dyspnea, and second, what is the second symptom? Hello.
So second symptom is loss of weight, which is present since 3 months.
Okay, any person coming with loss of weight, say for a few causes, or you can get significant loss of weight.
A significant loss of weight can be because of some underlying any underlying malignancy. It can be because of some any chronic inflammatory condition. Inflammatory condition in that particular patient. It can be because of nutritional deficiencies.
Yes. GIT disorder. Okay, you told. Okay. Chronic malabsorption syndromes. Yeah. Then chronic infection like TB, malignancies. Then other causes.
Any sort of chronic inflammation, even involving thyroid gland, also can cause loss of weight.
Thyrotoxicosis, of course. Then, which infection? One is TB. Any other infection where you can get significant loss of weight? Hello?
HIV.
Yeah, then. Right, what is anorexia nervosa?
Hello?
In anorexia nervosa, will you get a loss of weight? Hello, am I audible? Hello?
Hello.
Hello. Am I
Hello.
audible?
Hello. Yes, sir.
Ah,
Yes,
okay,
sir.
okay, okay. In psychiatric problem, will you get loss of weight?
Yes, sir. We can get like in anorexia nervosa. Hello.
Right. So now he's having dyspnea, loss of weight. Say a few conditions where you can dyspnea, breathlessness, and loss of weight.
Sorry for
Uh,
interrupting. Can you start over?
Hello.
uh, Hello. Yes, sir. Sir, would you please repeat the
Ah,
question? Hello.
the question is, if a person is having breathlessness and loss of weight, some lung condition where you respiratory cause where you can get dyspnea, some endocrine cause where you can get dyspnea, breathlessness, and loss of weight.
In respiratory conditions, we can get most likely in case of malignancies,
Yes.
where there can be dyspnea along with loss of weight.
Yeah.
Even in case of pneumonia or consolidation because of decrease in the appetite of the patient, we can get same. In
Which
endocrine causes,
pneumonia? You mean tuberculosis? Endocrine?
endocrine causes because of the specifically because of the thyroid abnormalities, we can get a progressive dyspnea and along with loss of weight, as in hypothyroidism.
Hypo or thyrotoxicosis?
Yes, sir.
Which one?
Hyper thyrotoxicosis, hyper.
Okay, very good. Right. Then what is the third symptom for this person is having?
Yes. So would you please repeat the question?
You said dyspnea, then you said loss of weight. What is the third symptom?
Dry cough along with recurrent episodes of hemoptysis since past 1 month
Hemoptysis.
duration.
Okay.
Yes, sir.
So what is the definition? How will you define hemoptysis?
Hemoptysis is defined as association of blood in the sputum.
Then what is spitting blood?
Hello.
Hello.
Yes,
What
sir.
is
Would you
the
please?
actual definition of hemoptysis? Hemoptysis.
Sir, I don't know the exact definition, sir.
You don't know
The exact definition.
of hemoptysis.
Yes, sir. Presence of blood in the sputum.
Okay. Coughing out blood. Okay. Right. Then what is spitting blood?
Hello. Yes, sir.
What is spitting of blood? Spitting blood and hemoptysis. What is the difference?
Spitting of the blood can be because of the hematemesis, or it can be because of an oral lesion. So
Hematemesis
that
and spitting blood, are they same or different?
different, sir.
So my question is, what is spitting? Suppose a person is having some oral cavity problem,
Yes, he will
like
have spitting.
periodontitis or a malignancy or a telangiectasia, bleeding in the mouth. What will it
Yes,
produce?
sir.
Is it hemoptysis or spitting?
Spitting cough, sir.
So that is effortless or effortful?
It is effortless.
Yeah, effortless. Hemoptysis?
It requires effort. It is effortful and associated with cough.
Yeah, cough. Right. Okay, right. Say few respiratory causes for hemoptysis.
Hemoptysis among the respiratory causes, it can be because of tuberculosis. It can be because of a carcinoma.
Yeah.
It can be because of arteriovenous malformation.
Okay, then any other? Now, okay, right.
Yes.
Yeah. Cardiac cause for hemoptysis.
Cardiac causes for hemoptysis may be because of pulmonary stenosis causing black pressure in the pulmonary edema leading to rupture. There can be secondary hypertension which can lead to erosion of the pulmonary vasculature giving rise to hemoptysis. Infective endocarditis in rare cases.
You mean myocardic aneurysm involving lungs?
Yes, sir.
Arterial, huh?
Yes,
okay.
Sir.
And infarction. Okay, infection.
Yeah,
Okay, right.
Yes.
In mitral stenosis, will you get what are the mechanisms of hemoptysis?
In mitral stenosis, there is an increase in the back pressure to the lungs because of the stenotic mitral valve on the left side, which can give rise to pulmonary edema, which can give rise to a pink frothy sputum
Yeah.
most likely. However,
Yeah,
if there
then,
is a significant increase in pressure, it can lead to rupture of the pulmonary or the bronchial veins and can give rise to hemoptysis.
good. Then, any other mechanisms? Other mechanism of hemoptysis in
Hello.
mitral stenosis. Other
Hello, sir.
mechanism of hemoptysis related to
Hello, sir.
mitral stenosis. Hello, audible?
Hello, sir. Would you?
Hello, 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 audible?
Hello, check number 2. Can you hear me?
Some net problem there, I hope.
Unmute yourself and speak. Hello? Can you please unmute yourself?
Hello, hello.
Hello, yeah. I can hear
Hello.
you.
Can the organizers please sort this out? The time is getting.
Hello. I can hear you.
Hello, sir.
Okay, right. Okay,
Hello.
all right.
Yes, sir.
Then you go ahead with your presentation, and now you combine all the 3 symptoms and say a few pathological possibilities.
Hello, sir.
Hello.
Could you please repeat hello?
Now, after
Hello, yes,
the
sir.
history of breathlessness, loss of weight,
Yes, sir.
recurrent hemoptysis, you say
Yes,
a
sir.
few pathological possibilities. Okay.
Based on the basis of the given history, along with recent onset right-sided pain, the most likely etiology can be a right-sided collapse of the lung. It can be because of a neoplastic cause. It can be because of the history is not suggestive over here, but it can be because not because of loss of fever, but it can be because of tuberculosis cavity on the tuberculosis also can be a cause for the same.
Okay, right. So you are thinking malignancy or a tuberculosis, isn't it?
Yes, sir. Yes, sir.
Between these
Yes,
two,
sir.
what is your first choice? Malignancy or TB?
Yes, malignancy, sir.
Malignancy. Okay, right.
Yes.
So which side? Which are the side determining symptoms and in respiratory system? You can say right side or left side. What are the?
So,
Is it clear?
hello, sir. We will check in for the first of all. We will check in for the deviation of the superior mediastinum
No,
or the
that is no. From the history, you can find
Yes,
out
sir.
which side is affected, right or left. So, what are some clue from the clue from the history?
Right side, because there is a history of right-sided chest pain.
Chest pain.
It is given
Okay.
that there is right-sided chest pain, so it is more likely to be of the right side.
Okay. So, is it a
Yes,
fixed
sir.
chest pain or a pleuritic chest pain? What type of pain is this?
It is not likely to be a pleuritic. It is not likely to be a pleuritic chest pain because pleuritic chest pain will be very sharp in character.
Okay, so it's a constant dull type of pain. Maybe
And
something
it will
will be
be
infiltrating the chest wall,
yes.
isn't it? Okay, right.
Yes,
Go
sir. Yes,
ahead.
sir.
Yeah, with your general examination findings.
On examination, there is right supraclavicular lymph node which is palpable. There is drooping of the shoulder on the right side. And on percussion, there is an impaired note in the right supraclavicular, infraclavicular, in the right mammary area, in the right axillary area, posteriorly in the right interscapular and the suprascapular area. And on auscultation, there is decreased breath sounds in all these areas.
Okay, my question is, what are the anatomy of? Tell me the anatomic. I mean, oblique fissure and horizontal fissure, surface anatomy. Oblique fissure.
Hello.
Can you hear?
Hello.
Oblique fissure. Oblique fissure, surface anatomy.
Oblique fissures are what?
Surface anatomy. From where it starts, where it ends. Oblique fissure.
10 minutes.
From the on the medial side, from the fourth. Hello.
No, backside you start. Hello. Which spine it starts?
Hello. Fourth level.
Huh?
Hello.
T7. starts at the spine level and at which coastal control junction it ends.
Yeah, around four.
Fourth or sixth?
Hello.
Third thoracic spine and
Fourth.
sixth costochondral junction, a line drawn when you connect these two, that is oblique fissure. Then horizontal fissure start from where? Hello?
Hello. Hello, the voice is not audible.
Hello, chest number 2.
Hello?
Yes.
Hello,
Hello,
chest number
Am I audible?
please, coordinators, please sort this off. Hello.
Hello? Hello?
Hello,
Hello?
yes, sir.
Okay. Horizontal
Hello, yes,
fissure,
sir.
where it starts, where it ends. Because without knowing this, the respiratory system will be very difficult, no? Because you should know where is upper lobe, where is the middle lobe, where is the lower lobe. To understand this, no, you need this anatomy knowledge. Oblique fissure, horizontal fissure. Horizontal fissure starts where and ends where? Because the middle lobe is between the oblique fissure in front and horizontal fissures, isn't it? And above the horizontal fissure.
Along the fourth rib.
Fourth costochondral
Along the
junction.
fourth rib, sir.
Okay,
Yes,
forget about that question. You study that well. Okay. Then only you will be.
Okay.
So here the findings are confined to which lobe? Hello?
Right-sided upper lobe.
Right upper lobe,
Hello,
isn't it?
right-sided upper lobe.
Right upper lobe. Okay.
Yes, sir.
So what do you think? Auscultatory findings.
Hello. Yes, sir.
Proceed with auscultatory
Auscultatory
findings.
findings, there is a decrease in the breath sound, sir.
Decrease in the breath
Hello.
sound in the right upper lobe region, isn't it? Infraclavicular, supraclavicular, upper interscapular area, supraclavicular, scapular, and axillary region. There is a reduction in breath sounds, isn't it? Okay.
Yes, sir.
Okay. That is breath sounds. Any
Yes, sir.
added sounds like crepitation, ronque,
No,
or rub?
no adventitious sounds.
Any bronchial breathing heard?
No adventitious sounds.
Okay. No, adventitious
Hello?
is for cardiovascular and added for respiratory. Added for respiratory and
Hello?
adventitious for cardiovascular. Can you hear? Hello?
Hello. Yes, sir.
Okay.
Hello. Yes, sir.
Yeah. So what do you think? Here, diagnosis possibly fibrosis or collapse.
Collapse of the right-sided upper lobe.
Right. Why not fibrosis? Why not fibrosis? Why can't be right upper lobe fibrosis? Hello.
Hello, sir. There is also a palpable lymph node which is palpable, which is more likely suggestive of a malignancy in this case, because of which there can be a collapse.
Yeah. What type of collapse is absorption collapse or compression collapse?
It is more likely to be a compression collapse. It can be both. It can be compression as well as absorption collapse. Absorption, if it goes on to invade in the inner structure and the walls of the conducting system.
Yeah, so growth you are suspecting is inside the right upper lobe bronchus, isn't it? That is producing,
Yes,
or a
sir.
lymph node may be compressing. Okay, right.
Yes, sir.
What are the general examination findings? Other one is lymph node. Anything else?
Nothing else has been mentioned over here, but I would suspect there would be clubbing also, which would be present in this particular patient.
In the general examination, is
Along
there
with
any
that,
clubbing?
yes, sir.
General examination finding only scalene node. Any other finding?
No, sir, they have not mentioned anything over here, but I expect that clubbing can also be present. Also, I would like to check in for the peripheral pulses because the patient is a smoker.
Okay, you are suspect. You want to know. Very good. Peripheral vascular disease. Okay, atherosclerosis. Okay. So right. So your diagnosis right upper lobe. What about the
Right-sided
lymph
upper
node?
lobe collapse, most likely due to malignancy.
Malignancy. Okay. Okay. Right. Very good. Very good. How will you investigate?
For investigation, first of all, I would like to carry out the basic investigations, the CBC, hemoglobin, ESR, Along with that, I would like to go for the sake of completion, serum electrolytes, LFT, RFT, along with urine examination. Moving on to appropriate proper investigation, radiology, I would like to go with X-ray and a CT scan.
Suppose you are suspecting bronchogenic carcinoma, his
Yes, sir.
electrolyte is 130 sodium. That is normal or abnormal? 130 milliequivalents.
130 milliequivalents is slightly low, but still fine.
Low. Okay, low. Potassium is 5.
It's 5 is in the normal, near about normal range.
So what condition will you suspect with this electrolyte abnormality in a person with bronchogenic carcinoma?
Can it be symptom of inappropriate ADH secretion, which can give rise to hyponatremia?
Yeah, that is hyponatremia, but the hyperkalemia hyponatremia combination in a person with CLN indicates what? Hyperkalemia, hyponatremia, and sometimes blood sugar will also be low.
Blood sugar is also low. Bronchogenic carcinoma.
Okay. One more. You have 2 more left. 2 more.
One more.
One more. One more. Okay. Last. Okay. Right. Call.
Okay, I'll call the third test number. Hello, test number 3. Hello, test number 3. Am I audible? Can you please unmute yourself?
Hello.
Hello. Hello.
Good morning, sir.
Yes. Good morning. Audible?
Yes, sir. Am I audible to you?
Yeah. You're audible. Okay. Go ahead with your presentation.
Sir, a 32-year-old female. She gave a history of polyarthritis for past 6 months, and also there is a history of ANA positivity. Now she presented with acute onset of weakness of the left body for 2 days. Also, she complained of double vision on looking on left side. It was horizontal type of diplopia, and it was more on looking near objects rather than at distant objects. There is no history of drooping of eyelids, no other symptoms pertaining to any higher mental functions or cranial nerve involvement, no extrapyramidal involvement. Sir?
Okay, no symptom attributable to dysfunction other cranial except for this double vision.
Yes,
no.
Sir.
Okay, hair function and other cranial not involved. Then
are normal. Extrapyramidal no involvement of extrapyramidal system, no sensory abnormality, no abnormality in bowel and bladder functions.
Test number 3. Can you put on your video?
Okay, I'm hearing you. I can hear you. Okay.
So shall I continue?
Continue. Yeah.
Yes, sir. So examination slide, please. Okay. So on examination, there is impaired
1 second.
addiction.
No? After this history,
Yes,
because
sir.
your analysis of history is very important, and how you are approaching a case, that's the most important thing. No? How is your approach? So
Yes,
let us go with your evaluation of this patient's symptom analysis and
Yes,
anatomical localization. That's the most important thing in neurology, isn't it?
Yes, sir.
Okay, so you analyze the history and fix anatomically the lesion.
Yes, sir. Sir, I would like to start with the history. She's a 32-year-old female. So she belongs to childbearing age, and she's a female. She also gives history of polyarthritis. And also the ANA is positive. So with that history, yes, sir. So with that history, I do suspect a vasculitis like SLE, secondary vasculitis like SLE, because of the age, the predisposing age, and the polyarthritis history. Also, the screening test, which has good sensitivity, like 98% it is positive. So next slide, please. Okay, now with the history of symptoms. She said there is acute onset of weakness of left body. So for 2 days. Also there is double vision on looking left, on looking towards left, and more on looking at near objects than distant. So acute onset suggests to a vascular etiology of cerebrovascular accident. Then she also gives an history of double vision. So probably there is
No, she has
approach to
weakness. No, weakness indicates due to, is it an upper motor weakness or a lower motor axis
Sir,
weakness?
with this much history, it's just given that acute onset of weakness. So most probably, maybe with the examination, we can more confirm that it is due to a UMN lesion or with
Now
other.
you are suspecting. So now this presentation with
Yes,
double
sir.
vision and one side of that is weakness of left
Yes,
half of the
sir.
body, that is hemiparesis or plagia.
Yes, sir.
So is it an upper UMN or LMN?
Sir,
Lower motor
UMN.
neuron axis.
Sir,
It
upper
must
motor
be
neuron lesion.
upper motor neuron. Upper
Yes,
motor
sir.
neuron axis, you say.
Yes, sir. Yes, sir. Axis.
Because if you are saying that the lesion is in the brainstem,
Yes, sir.
you are mainly suspecting the white matter involvement, that's isn't it?
Yes, sir.
So
Yes,
it is
sir.
upper motor neuron axis.
Yes, sir.
Okay. Then, okay. So, right. So, then you have to go details of that visual problem.
Diplopia. Yes, sir. When a patient comes with diplopia, first of all, we should rule out whether it is an ophthalmic case or if it is a neurologic. So we should know whether it is an uniocular diplopia or binocular. So I would like to ask the patient to close one of the eye. So even if after closing either of the eye, if that diplopia is persisting, it means it is an ophthalmic case. While diplopia only present if both the eyes are kept open, that means it is binocular diplopia and a neurological cause, most probably.
Okay.
So here the patient complains of diplopia looking more on left side. That is it is a binocular diplopia and horizontal diplopia. Horizontal diplopia can be due to some of the causes for horizontal diplopia are internuclear ophthalmoplegia, vestibular nucleus lesion, or vestibular nerve lesion. These are some of the causes for horizontal diplopia. Now, the patient also complains of nystagmoid movement. Oh, sorry, that's on examination. Sorry, sir. Should I say that it here?
Okay. So now with this what are you suspecting the reason behind this devolution?
Sir, most probably due to internuclear ophthalmoplegia. That is a lesion at the MLF.
Why not third nerve related diplopia?
So she gives no history of ptosis.
Why not a lateral access related devolution?
Sir, only the diplopia is present only in adduction, not in abduction.
In upper motor neuron lesion, will you get diplopia?
Yes, sir. Yes,
upper
sir.
motor neuron, corticonuclear fiber involvement, will you get double vision?
Yes, sir. The MLF, when an MLF is involved.
Okay. Right.
Medial longitudinal fasciculus.
Okay. Go ahead with your presentation.
Yes, sir. So there is no other history like drooping of eyelid, no higher mental function features, no other cranial nerve involvement, no extrapyramidal involvement, no sensory abnormalities, no bowel bladder dysfunctions. So now coming to examination, there is impaired adduction of the right eye. And the left eye shows nystagmus on abduction. So this means that there is a lesion.
What about other cranial nerve involvement?
Sir, no other cranial nerve involvement.
Okay. So where is the lesion?
Sir, medial longitudinal fasciculus.
Which side?
Right side.
Right?
Of right side. Since the patient has adduction difficulty of the right eye.
Is there any involvement of paraponderal reticular formation?
No, sir, because the lateral rectus seems to be normal. The lateral abduction is normal.
Okay.
10 minutes.
So, pardon? 10 minutes over.
12, yeah.
Okay. No problem. Right. Okay. Right. Proceed. Go ahead.
Now the left eye shows nystagmus. That is, the nystagmus is confined to the abducting eye. That
Okay.
means it is a jerky nystagmus, gaze type nystagmus. So again,
Okay.
pointing towards MLF lesion.
So where is this lesion of MLF happen here? Is it in the pons or in the midbrain?
Sir, I don't know, since there is no other features of other cranial nerve involvement or other features like red nuclear involvement or myoclonus or tremor. I think most probably it is involvement of midbrain, where MLF is also involved, as well as due to the weakness of left side. There is hypotonia and extensive plantar on left side. So pyramidal tract is also involved. So
Why there is hypotonia?
Sir, maybe neuronal shock. It's just 2 days of presentation. So maybe she is in neuronal shock of UML lesion.
Okay, is there any cerebellar signs on left side?
No, sir.
Why?
Sir, left. No, sir. ML. If there is no involvement of superior cerebellar peduncle.
No, is there any cerebellar signs elicited? Left is weak, left side, hemiplegia is
Yes,
there.
sir. Yes,
In
sir.
that side, is there any cerebellar symptom or signs?
Sir, I have been given this case. It doesn't say about cerebellar signs.
No, what is the power?
Sir, power is grade 2. Grade 2.
Then what is my question?
Sir, ataxic hemiparesis question.
No, with grade 2 power, will you be able to comment about this, whether the cerebellum is involved or not?
No, sir.
Yeah.
No, sir. More than 2 is required for that.
Yeah.
Yes, sir.
Right. So your localization is where?
Sir, medial midbrain, most probably due to basilar arteries. Medial midbrain, affection of
Medial
MLF.
midbrain or pons?
Sir, there are no other features of cranial nerve involvement or other features like myoclonus or tremors. So,
may not be
or maybe
needed.
superior pontine. Maybe superior pontine. Yes, sir. Maybe superior medial pontine lesions affecting MLF. Yes, sir.
Okay. So she's having polyarthritis with ANA positivity. That indicates what?
Sir, SLE, systemic lupus erythematosus.
Now you correlate SLA with this presentation.
Sir, SLE, the most common nervous system manifestation is cognitive dysfunction. But here it can also cause other features like mood depression, mood disabilities, and as well as stroke and TIA, transient ischemic attack. So in this case, I suspect stroke due to SLA since there is no other history. Since this is a case of young stroke, and we should also rule out the other possibilities related to this since she is young lady, for example any rheumatic heart disease or any procoagulant conditions like protein S deficiency, protein C deficiency, antithrombin deficiency.
That's very good. Wait,
also
again, if you are suspecting mid-brain stem involvement in this case now,
yes, sir.
You are suspecting an artery SLE antibody mediated or vasculitis like that part.
Yes, sir. Yes, sir.
Vasculitis, no?
Yes, sir.
Which vessel?
Sir, basilar artery. Since it is medial, we are suspecting.
How is the basilar artery formed?
Sir, basal artery is formed by the combination of two vertebral arteries, and then it gives branches like paramedian branches, short circumferentials, which will supply the lateral part of midbrain, and long circumferential or the superior cerebellar artery, which will supply the superior cerebellar peduncle. And in this, since this is a SLE case, it can be due to many mechanisms like embolism, cardiogenic, like in SLE, there is increased risk of Lidman-Sachs endocarditis.
You forget about embolism, atrial fibrillation, all very unlikely.
Vasculitis.
Now vasculitis, and I want to know which is it a main basilar artery that is blocked here? Is it a stem of basilar artery got occluded here?
No, sir.
Why?
No, sir.
Why?
Sir, since other features, there are no cerebellar features also, there are no other pontine features, since these are also supplied by the basilar artery. So if it was a stem occlusion, these features should have been there.
Very good. Right. So which artery is it? A short circumference? I mean, so which branch is it occluded of basilar
Sir,
artery?
since I'm suspecting an MLF lesion, therefore there should be a lesion in the medial midbrain or the superior medial pons. So most probably paramedian branches of basilar artery.
Very good. Right.
Yes.
That's it.
Yes,
Okay, so SLE vasculitis involving brain stem is your diagnosis with producing a lacunar stroke syndrome-like presentation, isn't it?
Yes, sir. Yes, sir.
You have also discussed about protein C has and heparin cofactor deficiency and antithrombin,
Yes,
all those things, young stroke,
Homocystinuria,
homocystinuria,
sickle
etc.
cell anemia, aortic dissections or AV malformations. These are also causes for young stroke.
Okay. Right. Okay. So which poisoning substance can produce stroke?
Sir, poisoning. Sir, methyl iodide, pesticides like methyl iodide can cause vascular occlusion. Then,
Yeah, it can produce. Yeah.
Then,
Which?
sir.
Sorry. Right. You're correct. Methyl iodide can produce this.
Yes, sir.
Any bite can produce stroke.
Sir, viper venom. Normally, it inhibits clotting, but due to presence of procoagulant factors like serum protease, they can or phospholipase, they can cause clotting, occurs and vascular occlusion can be resulted.
Okay, stroke, especially viper bite can produce.
Yes,
Isn't it?
sir.
Very good. Yeah,
Yes,
right. Okay, right. Okay, how will you evaluate this patient? Evaluation.
Sir, first of all, I would like to start with a non-contrast CT to rule out any hemorrhage. Then, of course, the blood should be given for routine examinations. Like here, especially for ANA, it is positive. So, anti-double-stranded DNA should be tested because it has a special prognostic value for CNS complications in SLE. So, anti-double-stranded DNA, then ESR, then other blood sugar, and also check. We should check for the protein C and that is procoagulated states. Then CT angiography will be a gold standard in this case because vasculitis is being suspected. So CT angiography should be done. Then it will show if there is any vasculitis, aneurysms, or any accelerated atherosclerosis and all.
What about then, MRI diffusion?
Yes, sir. MRI is the most accurate investigation is MRI, diffusion perfusion scan, and diffusion flare should be done.
Okay, so suppose the diffusion, her MRI imaging in the first 3 hours of the initial presentation showed a very small lesion in the parapontine region of the pons, which diffusion restriction. That indicates which vessel involvement.
So parapontine region.
Parapontine region is a very small, paramedian
branches of basilar artery.
Okay, how will you manage in that situation? SLE and a small diffusion.
SLE also, since this is a case of SLE as well as stroke. So, and since this is not just a mild flare of SLE, so I would give immunosuppression as well as the management of stroke, so as to reverse the brain injury as well as to prevent. So for immunosuppression, pulse therapy can be given like with
that is later
stroke. Okay, for stroke. Yes, acute stroke. First of all, the BP should be maintained. It should not go beyond 110. Then, if there is any features of cerebral edema, IV mannitol should be given. Then,
in this patient, I have already given you the scenario. There is no very small lesion. Will you give mannitol?
Sir, no, sir, not in this case. Yes, sir. So thrombolysis can be done.
Thrombolysis, because you are suspecting whatever whether vasculitis or you are suspecting a little thrombus.
So thrombolysis will be done using RTPA.
Then you will get steroid, isn't it?
Yes, sir. Steroid immunosuppression, pulse
other
therapy.
drugs used in the treatment of SLE?
Sir, In case of flare, we give pulse therapy. Otherwise, we give oral prednisolone and then followed by steroid replacing agents like hydroxychloroquine, mycophenolate mofetil, azathioprine, etc.
Very good. Very good.
Then also B suppression and IV rituximab and belimumab can also be given in that case.
Okay, very good. Thank you.
Thank you, sir. Thank you, sir.
Right. That's all, no? Third case, what is that?
Thank you, sir. Thank you, sir.
Hello?
No, sir. No, sir.
I can leave.
Okay, thank you.
Yes, sir. Sir, that is
Thank you all.
Hello, sir.
Okay, over now.
Yes, sir.
Okay, thank you. Thank you. It was a very interesting session. All performed well.
I would like to use this opportunity to thank Dr. Suresh for joining us despite his hectic schedule. Thank you so much, sir.
Okay, bye. Good day.
I hope everybody has a great day ahead. Thank you.